Okay, good morning, everyone, and welcome to this second day of the annual conference of the Partnership on Transforming Health and Care System 2024. Yesterday, we welcome also to those who are connected online. Yesterday, we had a rich and inspiring discussion on the challenges we are facing, the actor involved, and opportunities and resources available in the process of transformation of health and care system. And today we have other two sessions that we hope will be no less remarkable. So the first one is dedicated to the projects founded under the Joint Transnational Call 2023, launched last year. On healthcare for the future, and in this panel, we had the chance to listen to the fantastic work of the projects that had been selected, of 4 projects that were selected for this call, and will be guided by Annalisa Cartabia, senior executive at THCS Malta and part of the work package 8 at THCS. And after this session, we will also have the chance to present the Joint Transnational Call 2025. And we have after we will have a short break, coffee break, and then a second session dedicated to the partnership of the cluster health, with a focus on some of the partnership ongoing, and but not just the partnership, also some important and interesting initiatives under the Youth for Health program, as the joint action on National Focal Point for Health, and we will discuss the importance of synergies between all these initiatives that can be really important and can shape the future of our health and care system. So I want to give the floor to Annalisa to present the panel and enjoy the session. Thank you very much.
All right, so good morning also from my end. Thanks for the introduction. As mentioned, yes, I'm Annalisa, representing Scienza Malta, which is the national funding organization for research and innovation in Malta, of course. And it's my pleasure today to be moderating this panel on behalf as well of THCS Work Package 8. And just for who is less, let's say, confident with the partnership, the Work Package 8 oversees the monitoring of the project awarded under our program, THCS. And finally, I would like also to extend my gratitude to the coordinating team of THCS for giving me this opportunity this morning. So in this third session, we will hear from 4 project coordinators, as already mentioned, showcasing their funded projects, which were awarded during our first JTC, Joint Transnational Call 2023. Also, what is interesting is that the project coordinator will answer to 3 questions that we asked them. So how the projects contribute to transforming health and care systems, of course, the required ecosystem to successfully implemented in their project, and the strategy for disseminating the fundings to a wider public and, of course, policymakers. Following each presentation, we hope to receive some questions from the audience as well, so to keep a nice conversation and discussion. Before we begin with the project presentation, we'll start with a brief introduction for those who are less familiar with the THCS transnational calls. And this presentation will be performed by the leader of the call secretariat, Denise, who is here with us today. And will provide just an overview of the modus operandi of the calls. Then will be followed by a short video summarizing the results from the first joint call 2023. And this will be basically setting the stage for the project coordinator presentation. So it's now my pleasure to pass the floor to Denise for the short presentation. Thank you very much.
Good morning. Welcome. I'm the leader of Work Package 7, which is the Joint Call Secretariat. In our wisdom, we decided that our funding pillar would be divided into three to make sure that it's a continuous flow. So what I'm going to tell you is also a work from our other colleagues who are in Work Package 6, who work on, let's say, the topic. We work on the procedure. As Annalisa just told you, she's doing the monitoring. And I have the honor to explain this procedure to you in less than 2 minutes. So it's going to be interesting. If you have any other questions, please, during the coffee break, or else just ask me whatever it is that you would still like to know. I only have one slide, so it's going to be quite easy. One slide with a lot of information. We start at the call planning and preparation phase. That phase is based, of course, on what the input from our strategic research and innovation agenda. And during the topic selection phase, input is collected from all members from THCS to make sure that we all agree on the most interesting topic. Most of the time it's 3 or 4 topics that can be chosen. And the final decision is made by the funders of the call, because the rule, as my mother always says, the payer decides. The funders agree on the scope and the conditions of the call, and which all come together in what we call the call text. And the next phase is then the submission phase. The proposals are submitted via an online tool, and in the current call, you will hear later, we have a pre-proposal phase and a full proposal phase. And after submission, they go through a central and a national regional eligibility check, which is most important. That is important because in joint transnational calls, the funders only fund the applications and researchers from their own country. So that's why the eligibility check is of importance. The next phase is the evaluation phase. During that phase, the eligible proposals are assessed by 3 independent reviewers, and the applicants can comment on the report during the rebuttal phase, and the pre-review panel per proposal assesses the review reports and the rebuttal and agrees on the final ranking. This is the most important phase because the outcome of that phase can decide the place of the proposal in the ranking list and whether or not you're being recommended for funding. That's during the evaluation phase. And then we have the final decision. Once the ranking list is available, then all the funders meet in a meeting to discuss which proposals will be recommended for funding. And those are quite exciting meetings because that's when the budget comes into play and choices have to be, sometimes very difficult choices have to be made. And since each funder funds its own national and regional applicants, as I already told you, a proposal recommended for funding will then enter the national and regional funding procedure. That's why the proposals are recommended for funding, and we don't say that they are going to be funded, which is an interesting distinction. And after the call, the progress of the funded proposals is followed and monitored by a monitoring procedure. And so they have to give yearly reports, and also they will come to a review boards. And we are hoping to hear some exciting first insights and maybe some tiny results from the proposals I'm going to present later. That's it from my side. That's the cycle. Any questions?
Yes, in fact, I wanted to thank Denise for the very precise presentation slide, I would say. We are, yes, maybe a couple of minutes if anyone has questions. Otherwise, you can take them at the coffee break for sure. We'll be here available for your further questions. None?
No.
I think we're still starting the day, so good. We can move now to the short video prepared by the THCS coordinating team on the main results of the first Joint Transnational Call 2023. Thank you.
Joint Transnational Call 2023, launched by THCS, aims to encourage the optimization of patient care pathways and contribute to the transition towards more sustainable, efficient, resilient, ethical, high quality, accessible, people-centered healthcare of the future. The two main objectives of the Healthcare of the Future call were to provide the necessary knowledge to build the health and care of the future, to support the implementation of innovative solutions on a larger scale. 162 eligible full proposals were submitted, which brought to 28 funded projects for an overall JTC 2023 success rate of 17%. When we break down the thematic building blocks of the awarded projects, the focus is on shaping the healthcare of the future through key priorities. Digitalization. 63% of the projects are driving the digitalization of healthcare systems. Safety and quality of care, also representing 63%, ensuring that care is both safe and effective. People's needs and user involvement. 14.8% of projects are prioritizing user-centered approaches to healthcare. Health and care, workforce skills. 7.4% are addressing the skills gap in healthcare workforces. Efficiency and sustainability. Another 7.4% are working to improve the sustainability and efficiency of healthcare systems. The JTC 2023 awarded projects are focusing on the following research areas: neurology, aging, psychiatry, stroke, hypertension, cancer, pediatric and neonatal care, and other chronic conditions. JTC 2023 numbers: 28 projects funded across 20 countries. More than 35 million euros invested, with a top-up investment of 6.6 million euros from the European Commission, bringing together more than 150 organizations. 36 funding organizations involved. This joint transnational call is driving change on an unprecedented scale. A network all over Europe and beyond, connecting institutions, healthcare providers, patient organizations, universities, and private sector innovators. Together, THCS is building health and care systems where innovation transcends borders. THCS. Each of us can make a difference. Together, we make change.
Great. So I think this video really set the stage for what we're going to listen now, our 4 project coordinators here with me. And as I mentioned, it's a bit of an interactive panel discussion. So after each of the presentation, we would like also to receive some questions from your end and discuss a bit, perhaps any curiosity and anything you would like to ask. So it is my pleasure now to introduce our first speaker, Professor Ionut Engel from the University of Cluj-Napoca in Romania and project coordinator of Transcare project. So I leave the floor to you and thank you very much.
Okay, good morning. First of all, I want to thank the organizers for inviting us here. I think we also very nice presentation, very interesting presentation yesterday, and I'm sure that we'll see today. And it's nice to get a glimpse of the impressive work that THCS is doing in this project. Now I should introduce myself a little bit. My name is Ionuț Angel. I am a full professor of computer science. I come from Transylvania. Maybe you hear about this region in Romania, in a city called Cluj-Napoca, which is a university city. And I am involved in research projects from 2006. Have been part of FP7, Horizon 2020, Ambient Assisted Living, now THCS and Horizon Europe, and hopefully FP7, FP10. Now, what is the project that I am going to present? The acronym is TransCare. It comes for defining new care pathways for supporting transitional care from hospitals to home. And it started from an idea because in Romania, in Transylvania, apart from vampires, we have issues with the healthcare system, with the care pathway. And I must tell you that I had such an issue when my mother was diagnosed with coronary disease 2 years ago. And after the intervention in the hospital, when she was discharged, the doctor said that, okay, after 1 week or 2 weeks maximum, you should come back and get in the hospital for checking again the parameters. Then I asked, okay, but can we do it remotely? No, it's not possible in Romania yet. I mean, it's not the care pathway. This is the care pathway. She needs to answer some questions when she comes to the hospital. We need to check the parameters, the heart rate, I mean, the effort that is correlated to the heart rate. And then I thought, okay, but from other projects, maybe I saw different things that we can use IoT devices, we can use monitoring devices now to assess remotely, to stay in contact with the patient. No, this is not the way. So this is basically the idea of the project. And it's a project that reunites some partners from previous projects, from different areas, from research areas, from the industry, and of course end users. We also saw the end user importance yesterday in I think Anka's presentation. So it started from this idea. We have submitted the proposal, having in mind the issues and needs that are mentioned on these slides. I mean, most of them have been discussed today, and I'm very glad that I've solved them yesterday in the presentation, because then we have targeted well the needs for THCS project. But mostly they are this, we have so many digital solutions, but their usage is sparse. They are not interconnected or used together to solve a real problem. The lack of assessment, of a clear assessment, especially in different countries in Europe. We do it differently everywhere. And one of the most important things, the poor communication with patients, because from my previous expertise and from my previous experience in projects, social part and communication with patients is very, very important. Just shortly, I'll try to be brief, but I remember that I've been in a European project where we deal with providing food in Spain, in Andalusia region. It was a company called Culinaria. We built a system that recommended food given the patient disease or profile from different providers. And their most important thing was the interaction with the people that brought the food to them. There are people that were lonely, and the social part was the most important thing from that project. The interaction with the people that brought the food, they discussed with them, said to them, there were lonely people that said to them problems and things like this. So the lack of communication, at least in our country, and I give examples from my country because I know a little bit the context there. So the lack of communication is a very important need that needs to be solved. Now we also seen yesterday the reimbursement rates, which is another problem that needs to be tackled in future care pathways, because the reimbursements are done differently in Europe, or are differently in, let's say, public and private hospitals. So taking this into account, we have defined several objectives for our project. And the most important one is to redesign the care pathways, to analyze the current care pathways in countries in Europe, and try to define new pathways that can adapt or be flexible enough to be applied and to integrate technology and communication as main pillars. On top of this, of course, we propose to develop a solution, a technical solutions that will allow for the communication and for remote assessment and monitoring of patients. That involves the keyword today, artificial intelligence. Of course, it's a very hot concept, this one. Internet of Things and different pieces of technologies all together. This will be validated in trials because we have 3 partners that will evaluate the technology that are currently in this phase of the project working to analyze the care pathways and to define, let's say, holistic care pathway. And that will do these trials in 3 countries. One is Romania, where you'll see we have a hospital, in Italy and in Norway. There are 3 different views over how care is done in Europe. As patients, you will use older patients, people with frailty problems, let's say, as our partner always underline, people that have multi-comorbidity and that are frequently rehospitalized after some time. And the final objectives focuses on providing some guidelines, because I heard also in the presentation yesterday we need to provide something back to THCS, and I think this would be a very nice addition from our project to provide some guidelines, some lesson learned, some envisioned care pathways that can be the starting point for pushing it to higher levels and creating greater awareness. In the middle of these 4 objectives, we have the dissemination and awareness creation in several environments. Now, I won't bother you with the technological part, just to say that we have envisioned these 3 components that should be added and integrated in the path from hospital to home, the classical one, which does not involve technology. And these three components, one is dealing with remote monitoring. It's a complete remote monitoring platform that consists of IoT devices, not only smart bracelets, also clinical devices, blood pressure meters, smart scales, glucose meters, and everything that can be integrated in the infrastructure. Web platform, a mobile application, everything that allows for collecting data from patients remotely. Then we have a communication platform that is used to keep in touch with the doctors, with the nurses, with the carers, with the family, with the friends, informal, formal caregivers, or whoever needs to communicate with the patient. And this will be a flexible application that can be installed on the tablet, can be installed on the laptop, on the phone, and can be easily used by the end users. And then we plan to integrate an artificial intelligence solution, machine learning algorithms that analyze the data that is monitored and detect, let's say, some deviation, predict some situation, or offer help for practitioners to take a decision. We say that we support the practitioners, so this platform won't take a decision by itself. It's not ethical to do this, but will allow for doctors to see a more specific situation more clearly for them and to take a decision considering this information. This result of the machine learning will be pushed back in the infrastructure and in the web platforms for easy access from doctors. Now, the envision impacts. Well, our main goal is to assess if we can reduce hospitalization rate. I mean, this, from what I understood from our experts, from our end user partners, this rehospitalization rate needs to be evaluated at 30 days this is stated in the literature, and to see if there have been some rehospitalizations that were not planned. And we'll do this in the trials for long trials of 3 months, I guess. Now, the idea of including patients, we have around 200 patients. From my experience from previous project, this is a fair number. I won't say that this is a great number of patients, but from previous projects, I know that it can be much lower. It is always difficult to include patients, but what is the focus of the trial? It will be a 3-month trial. So it will be a longer trial that will allow us to assess the impacts that we define. Of course, we can find here all the key points that I saw yesterday in the presentations, and to reduce the costs, to improve the well-being, of course, of the patients that are forced now in some countries to go to hospital very often just to take the blood pressure and to make an effort test. And that can be avoided using digital technologies, to improve overall the coordination of the care system, and to propose these guidelines or care path matrices that can be used then further, can be refined further, and maybe we can have an impact at the European level or in some countries to improve things there. Now, to answer the 3 questions that are fundamental from THCS, how does our project contribute to the transformation of health and care systems? Where we envision this involvement of technologies. Yes, I know we all wear smart watches, we all have digital technologies and everything in our life, but it's kind of fragmented, the usage of these technologies. They are not even considered in some countries because they are not medical devices. From what I know, Apple Watch, for example, is approved by the FDA in the States. I don't know if it's other device it's approved. Fitbit has been acquired by Google and will be approved by FDA soon. So there are devices that we can use apart from the medical one, classical ones, but we can integrate them in this platform. We can use them all together, create a plan, a specific treatment plan for the patient, that when the patient is discharged, needs to follow a specific plan using specific devices at specific moments of time. Of course, there will be a seamless monitoring of the parameters using some kind of smart bracelet, but the other devices, they need to use it at specific moments of time and provide the data. And the innovation, again, is the integration of all these 3 pieces of technologies that already exist. I mean, they all been developed in previous AL projects. The monitor platform, it's already commercial one. It's prepared for commercialization. It's already commercialized, some parts of it in Norway. The communication platform, again in Norway, it's commercialized by our partners. It will be adaptive to the specificities because now it is developed for cognitive decline, but it will be adapted for the project needs. And the machine learning algorithms, well, this is developed in the project. This is new because we have this platform, this infrastructure. We have used it in other projects, but with different kind of algorithms. We are now in the moment of time in the project when we are deciding together with our partners what is relevant for them, what need this machine learning to provide for them in order to help them and support them in the decision-taking process. Now, how we create this ecosystem that needs to be relevant? Well, we have tried to build a very strong consortium with multidisciplinarity in mind. And we have research, we have companies, we have end users, and we even considered end users from different countries with different care pathways. They are all different in Italy, in Norway, and in Romania. And moreover, in Romania, we have a hospital, which is the biggest heart institute in Romania and one of the most important in Europe. We have INCA from Italy, which I think most of you know. They are in many projects. They are a very big institute in Italy. And we have a community center, which it's from Norway, from Farsund, a community that deals with helping patients in the discharge process from hospital to home. This is an innovative aspect because in Romania, for example, we don't have these communities that help patients to in the problems that occur after discharging from hospital. And now the final question regarding how we plan to create awareness to policymakers. Well, we envision a multi-channel dissemination strategy. We have used this in previous projects. We are experienced, let's say, with dissemination activities. The dissemination leader is experienced, but mainly it's a common approach in Horizon projects and in European projects that is split in 3 phases. I mean, in the first phase, you create awareness to general public and scientific community. You start creating the website, some materials that you use at the events. Then, as soon as you have results, you start pushing information to the stakeholders, to the healthcare ecosystems, when you have demos that you can showcase to them. And in the last phase, maybe you go to more industrial events, to exhibitions where you can show the technologies, or you can approach even SDOs for showing the results and what you have achieved in the project. Now we are in phase 1, but we have already participated to several events. We have created awareness for our project. So I think that this is the most important thing, to try to address different type of stakeholders and to create awareness specific for that. Of course, if we go to the general public with the presentation, it won't be so technical, but when we go to a scientific conference, then we'll focus on the, let's say, machine learning models to present more information there. So it will be targeted for each kind of stakeholder we envision that can allow us to create more awareness, and maybe they can help us to achieve something with this project and to push information further to enforce the results of the project, which I'm sure that it will have an impact, since THCS will help us to disseminate and to push forward our deliverables and our results. So this was my presentation. Thank you very much.
Thank you very much, Professor. Unfortunately, we are a bit running out of time, as always is against us. But maybe if we have one question from the audience, we can still get. No, you need some time to. Great, thank you.
Okay, you hear me? Yes. Okay, thanks for this excellent presentation and very interesting. Actually, I have 2 questions, but they are in a way related. First one is a usual one, is that as you work with elder people, it's always this problem with literacy and use of electronic device and communication device, etc. So how have you managed to make the thing more or less transparent for them? 65-year-olds are not elder people at the moment, I mean nowadays, but I guess some of them won't know how to use electronic device and and things like that. So how have you managed to organize things like they don't have any more things to use, electronic device to use or whatever? And the other question is regarding the recruitment, because as far as I saw, you just mentioned that they have to be more than 65, but I guess you have more criteria. Because if you look at the outcome with rehospitalization, 3 months is not that long. So what recruitment criteria will you use?
Okay, thank you for the question. Regarding the first question with the literacy, well, I get this from the Norwegian people, so they are very skilled with technology. We don't have any problem there. Indeed, in Romania and in Italy, we have this problem with technology, and we will try to make training with them. But the applications that the patient, I mean not the healthcare providers or the healthcare personnel, because they are skilled with them. The applications are running seamlessly for them. So if they have a smartphone, they will have an application for monitoring the parameters that will not need to intervene anywhere there. When they take the blood pressure, for example, they need just to push a button, and the information will be sent to the gateway from the phone that will push the information further. Indeed, for the part of the communication, you are right. It's a problem, because they will need to use this application to communicate with doctors and with friends and patients. But this, as Anka said yesterday, this application has been built with in AL projects where user-centric design and development was a keyword. So it was previously validated as a level of dashboard. So they are dashboards that are, let's say, close to the older people. And I think that in the inclusion criteria, related to the inclusion criteria, I think that we have already defined a draft version of the inclusion criteria. There will be specific inclusion criteria for each pilot because each is different. For example, in Romania, we'll have people that have coronary diseases and people with heart problems. In Norway, we have people with COPD. In Italy, we have frailty persons with comorbidities. And as inclusion criteria, I remember that in this draft that we are working on now, we have the age, as you said, it's 70 years old as the inclusion. And the working possibility that how to say it in English, it's like to a person that it's able to walk, because we need to measure the effort, and we need to include patients that can wear a bracelet, and we can measure the effort that they are doing correlated with the heart rate. And yes, there is a specific inclusion criteria regarding the language. They don't need to learn English, because all the tools will be translated if they don't know English language. So this is regarding to literacy. So I don't know if I answered your question correctly, but I have my friends and my partners from INCRA here if they want to add something about the inclusion criteria, or we can talk in the coffee break with them.
I think we have to move to the next presentation. If it's just a very quick question, right? Just another one, okay.
Can you hear now? Yeah, thank you. Alexandru Costescu from the European Commission. Congratulations for this project. I think there is a big need to ensure this kind of, let's say, remote medicine. So it's extremely important for people who are in remote areas, and quite often they do not have the means to travel to the hospital. So it's an issue that it's real in the population. The question that I wanted to ask is that for some people that have performed complicated surgeries, or they have, let's say, comorbidities, so they are complex situations, they need to be assessed in a professional way. What I mean is that the biomarkers that have to be sent to the hospital, they have to be taken professionally. So what I think is that you need some professional cares like nurses or medical assistants or some specialized people to take properly all these biomarkers to make sure that the information is reliable, in order for the professionals in the hospital to make an appropriate assessment, a realistic assessment of the situation. So that's my question. How do you make sure that the feedback that is sent back to the hospital is at professional level? Thank you.
Okay, shortly, thank you for the question. You are right. The platform that we are using for monitoring, that is called TeluWeb platform, is already used in Norway, and includes a carer for each patient. So a carer can be an informal or a formal carer that will oversee all the activities and will help the older adult to take the glycemic, for example, or to fill up a questionnaire. And it will be like a root account for the older person. It will always have access to the data before pushing it forward to the cloud for healthcare professionals to see it. So this is the way we did it in other projects.
Thank you very much. I appreciate that we need also to have the right resources in the field. Yeah.
Thank you very much for the questions. And now we can move to our second presenter, Assistant Professor Christian Olzebos from the University Medical Center of Groningen in the Netherlands, and Project Coordinator of ID Jaundice at Home. Thank you very much. The floor is yours.
Thank you very much, Madam Chair, to share our ideas on our project. It's entitled Early Recognition of Neonatal Jaundice, Application of Novel Preventive Strategies in Different Health Systems. And the abbreviation is ID Jaundice at Home. Well, what's the problem? The problem is neonatal jaundice. Neonatal jaundice is a yellow discoloration of the skin and the eyes. And that's because red blood cells are broken down and there's a yellow pigment released. It's bilirubin. And this bilirubin, the yellow pigment, it usually increases in the first 2-3 days and then levels off in term infants. But 5 to 10% of newborn infants need treatment because levels may also rise. And the danger is acute brain damage. Bilirubin, yellow pigment, can go into the brain and damage structures. And that can cause acute symptoms such as stiffness, as you see here in this picture, seizures, coma, and even death. This is a post-mortem specimen of a brain with yellow staining of the deep structures. And neonatal jaundice may also cause mortality. It's in the top 10 of many sub-Saharan countries and many Asian countries, the top 10 of mortalities, which is completely preventable. In our region, it's very scarce that children die, but they may develop chronic brain damage. And that's characterized by deafness and also by cerebral palsy, so a serious movement disorder. They are disabled for all of their lives. So early detection is really essential. And in many countries, this is done by visual inspection, like you see the family Simpson here. But that's very inaccurate and very unreliable. And when there's enough money, you can have a transcutaneous measurement of the yellow pigment. And this transcutaneous measurement is very much more accurate, but it's expensive. So we would like to use a smartphone app. With this app, a picture is taken from the newborn skin with a calibration card on his or her chest. And then the parent or healthcare provider gets an estimate of the yellow pigment level. Now, these are the work packages we propose. In the first work package, we propose to study the app in an outpatient clinic. The second work package, we would like to address the user friendliness of the app. In the second or the third work packages, we are going to study this app by giving it to patients, to parents at home. So all these projects are done in different countries, in Israel and the Netherlands, and they are done in different settings, outpatient clinics, hospitals, and at the home setting. We involve stakeholders, of course the parents, but also nurses, midwives, and pediatricians. And finally, we will also inventorize screening practices across Europe by a survey. And this is our project scheme. In year one, we already did the analysis of previous study, and that informed work package 1, which is now in the control phase actually. We already finished the mixed method study by giving the app to parents and asking them questions. So that's almost ready for analysis. We are busy with the preparation of the study in Israel and in the Netherlands by giving the app to parents. And during this process, the Norwegian partner, Pictures, they will take care of the iterative enhancement of the Pictures functionality and integration in the electronic health records. And we are already starting the European-wide survey of jaundice screening. So we are underway, maybe not halfway, but we are underway. Well, how does our project contribute to the transformation of health and care systems? Well, we hope that we can alleviate the burden of severe neonatal jaundice on patients' health and on hospital resources. We empower parents to take a more active role in their child's health. And we hope to make healthcare more accessible, more patient-centered, efficient, and potentially reducing dependency on in-hospital visits. And finally, we would like to expand telehealth capabilities and integrate more at-home screening tools into neonatal care systems. ID Jaundice at Home takes also into consideration the relevant ecosystem. We involve all key stakeholders, parents, midwives, pediatricians, and healthcare organizations. We recognize the different healthcare infrastructures in the Netherlands and Israel. And we will tailor studies, some of them are implementation studies, to each system, with midwives supporting the parents in the Netherlands and pediatricians providing support in Israel. We will gain insights, helping us to develop implementation strategies that are adaptable to the diverse healthcare settings. Of course, we will communicate the results of ID Jaundice at Home to the public and to the policymakers. We will publish results in open access scientific journals. We will present at healthcare symposia and neonatal conferences. We will create visually engaging content such as infographics and videos to share on social media and parent-focused platforms. And for policymakers, we will make reports on the effectiveness, on cost savings, and potentially reduction of the in-hospital burden. Thank you for your attention, and be happy to answer any questions.
Thank you very much for the very insightful presentation. Do we have any question from the audience? Perhaps? No? Otherwise, I actually have a question. So, and it was actually a question I wanted to ask before, but I think it's quite interesting. So in your project, you have 3 countries. So you are setting this new way, new technology in these 3 countries. But how you expect, and you already answered a bit during the question transforming the health and care system, but how you envisage this technologies, this technique to be used in other countries at European level or even beyond? Do you have any plan on that?
Yeah, it's a great question, because we envision that we are in a relative luxury position with 3 countries that have, well, good access to healthcare. Actually, this app might also be the solution for remote areas, areas which are well, developing. Because there the problem of neonatal jaundice is even higher. It may result in death, as I just talked about. So it's very important to know each healthcare system, to know how it is organized, and to involve these stakeholders from the beginning of the project. And that's also the reason why we also involve patient or parent federations. But parent federations, well, actually, they do not exist really. I mean, most of us are parents, but we are not organized in parent organizations. So that would be an interesting step. So we involve patient federations as a surrogate. And via involvement of these stakeholders and getting to know each health system, we hope we can, by exchanging ideas, expertise, and knowledge, we can find an innovative solution to transforming the health and care systems.
Thank you very much. Maybe any further questions on this project? No, I think everything was very clear. Good. So we might pass to our third speaker, Mrs. Sheila Calvo Almeida. He held Senior Researcher Engineer at Gradient, Spain, and Project Coordinator for iCare Wounds. And thank you very much. The floor is yours.
Okay, so thank you very much, Annalisa, and thank you, THCS, for having us here today. So my name is Zaira Calvo Almeida, and I'm the leader of the health team at Gradient. Gradient is an ICT research center based in Galicia, Spain, and we are the coordinators of iCare Wounds. So iCare Wounds project is focused on the enhancement of the chronic wounds management across the different European healthcare systems. So today we want to give a brief overview of what our project is about and to try to shed light about these lesser known ailments like they are the chronic wounds. So before starting describing our project, we think that it's interesting to let you know who we are. We are a consortium that consists of 7 partners from 5 different countries across Europe. Our consortia is formed by 4 different sectors. We have 2 technical partners, which are Gradient in our side, which has the knowledge of the artificial intelligence technologies, but we also have Sigoria Security Solutions, whose expertise is focused on the development of secure technologies from the healthcare sector. But for sure, we also need in our consortium the involvement of the clinical partners. In this case, we have 3 clinical partners, the Instituto de Investigación Sanitaria of Galicia Sur in Spain. We also have the Medical University of Buch, the University College of Dublin, and this, as I was saying, they give to the consortia the clinical knowledge, but they are also our clinical sites where we are going to perform our project pilots. As we are talking about healthcare, we also have for sure a legal and ethics partner, which is a Cyberethic Lab based in Italy, and a socioeconomic partner, which is the Lund University in Finland. So now that you know who we are, we also think that it's relevant before starting talking about our project to shed light about which is the real or the current situation with chronic wounds across Europe. So we try to summarize here which is the burden of the European countries regarding chronic wounds management. As I was saying, we think that this is a lesser known ailment, but it is true that we have a lot of people suffering from chronic wounds in our countries. We have like between 4.5 and 6.5 million people suffering chronic wounds per year. And this is for us a huge amount of people regarding how the impact that this type of ailments have on their daily lives. So we have this data from one side, but we consider it also relevant to explain more or less what a chronic wound is and to shed light also about the impact that it has on real patients' life. A chronic wound is a wound that whose mean healing time is higher than the common healing time. So we have chronic wounds that whose mean healing time go from 4 months to even more than a year. So you can imagine how it can be living with this kind of conditions day per day. So if we join this amount of people suffering from chronic wounds together with the mean healing times, we can also find out that the economic burden for our healthcare system is also high. What we find out during the research of our project is that the chronic wound management represented 5% of the total healthcare system budget. So we consider that this is also a relevant point. Now we know which is the burden. We consider it really relevant also to explain which are the challenges regarding chronic wounds management across European Union countries, both from the patient side, but also from the healthcare professionals. So as I was saying regarding patients, we know that living with chronic conditions and specifically with chronic wounds have a real impact on the quality of life of these patients, which are living day by day with chronic pain, with uncomfortable treatments, but also they have limitations, like for example, moving limitations that don't allow them to have normal lives, so to enjoy of their lives, right? but not also quality of life. They also experience some adverse events that can have a lower impact or a higher impact. These adverse events can go from infections on the chronic wounds, but also these exsanguations, which can be really hard to control, and in the worst cases, even causing deaths in our citizens. And regarding healthcare professional related challenges, we have that both the chronic wounds itself and both the patients that live with this condition are really real heterogeneous. Each chronic wound has its different tissues, and the treatments should be different regarding these different tissues that appear in the chronic wounds, but also patient characteristics could be different regarding comorbidities, regarding the specific conditions, socioeconomic conditions, everything. So this leads this together with the many treatment options that we and the healthcare professionals hand of the hands to select in the moment of treating our patients could be really challenging for them to select which is the specific or the better option, the better treatment option in each specific case. And we know that we have really good specialists in our healthcare system, but it is true that this kind of ailments need to have that specific knowledge on how to treat them. So we find out that we need to give some support in this field. So having these challenges, we proposed our eye care wound solution, which is focused on the implementation, the design and implementation of an integrated care model for the chronic wounds management. This integrated care model will be the basis for developing a e-health platform that could be a support for the healthcare professional in selecting doing the best decision making regarding the treatment options for our citizens. So I try to more or less simplify the architecture of our project in the slide you can see on the screen. Our platform will allow the healthcare professionals to do a continuous follow-up of our patients and the different stages of their chronic wounds during the time. And it will also include recommendations to the healthcare professionals to do this better treatment selection, right? So to do this recommendation, we have one of our core modules, is a computer vision module, which is able to analyze by a photograph, by an image, which are the present tissues on the different chronic wounds, and to propose to the healthcare professional the different treatment options that seems to be the better ones for this specific wound. But not just, we are not going to just give recommendations regarding treatment, but also, as it aims to be integrated care model, we also give information, taking as input international clinical guidelines about different, let's say, sectors of care, like hygiene, nutrition, that we consider that it also have relevance on how these chronic wounds are healing. So to implement this platform, we have divided our work in 4 different stages. First of all, we thought that it was really relevant to analyze how the management is being performed now in our healthcare systems. So this was our phase stage, reviewing the current chronic wounds management across the European healthcare system. We started from the 3 pilot sites we have in the consortium, and we hope that this approach could be scalable for the different European healthcare systems. So once we have analyzed this situation, we design an integrated care model. We co-design it with the different stakeholders to be ensured that this could be such a useful or effective solution. And now we are in the 3rd stage. We are defining how our platform is going to be performed basing on this design care, integrated care model. Once we have defined and designed and implementing our platform, we are going to do a multi-center pilot study in our 3 pilot sites, which are Spain, Poland, and Ireland. So answering the questions of THCS, how eye care wounds will contribute to the transformation of health and care system? Well, we identify 4 key points where we think that our solution could be a benefit. The first one is the early detection and earnest decision making, because we are using AI to provide the better solution. So we think that with these recommendations regarding the treatments, we could provide some benefits regarding reducing the healing times. Also, do that early identification of risk, like the ones that I mentioned before. But also we think that we can provide some standardized assessment protocols to the healthcare system. We also want to reduce optimize the resource use regarding dressings, regarding treatments, regarding the use of the hospital beds, for example, regarding complications. So we want to do a better use of our resources. And we also want to integrate the patient care regarding some better or some enhancement in the coordination between the different level of cares using our platform, and also improving that communication, right, between the different stakeholders. And for sure, we want to improve the quality of life of our citizens, of our patients suffering chronic wounds, because we think that this is the most relevant thing, right? Okay. How we are taking into consideration the relevant ecosystem was, I was mentioning from the very beginning of our project, we are considering the different stakeholders. We are analyzing how this management is being doing in the different healthcare system. We have real clinical staff in our consortium who is expert on this type of wounds management. So we are involving them in this analysis of the healthcare system. And we are also doing questionnaires to the different stakeholders to try to co-design efficient solution. But we are also trying to do the technological part based on the clinical evidence, taking into account the different state-of-the-art methods regarding the chronic wounds care and technology focus on that care. And once our project is finalized, we want to give more or additional clinical evidence-based medicine that could be taking into account to new opportunities for innovation. And just finishing, how will we communicate the scientific evidence of our project? Well, regarding the general public, we are using different channels, such as the social media, to give some insights of and try to shed light on chronic wounds to all the citizens, to all the European citizens. We are publishing some press releases regarding our project and also regarding the chronic wounds situation. And regarding policymakers, as I was saying, we want to our project to shed light on these real issues of the chronic wound citizens, and we also want our technology to also give us some insights of how these technologies could reduce healing time, reduce amount of money invested in this type of treatments, and give support to the policymakers to do these politics regarding chronic wounds management. And this is everything. So thank you very much.
Thank you very much, Sheila, for the insightful presentation. Do we have again a few questions from the audience? We actually got back with the time, so we still have some time for questions. No? I think the last two presentations were very clear. Seems that no further questions. So actually, I have one, and indeed, it's the first project that is Care Wounds representing more countries, as we saw so far, and quite some partners from different settings. You are representing a private entity, which is still also the first case so far. So how did you find the collaboration with your partners? Actually, even how did you got to know how you start building your project and how you're funding the collaboration so far within the project.
Okay, thank you for the question, Annalisa. Yeah, for us, we consider that involving the different types of entity is something really relevant because everyone has his vision regarding we are a technological partner, so we have our vision regarding technology, but as we are talking about technology applied to healthcare, we also need healthcare providers, which we consider that they are a fundamental partner for us to try to develop a real solution or real useful solutions for the healthcare. And in our case, we think that to build fruitful consortium, you need to align the different interests of the different partners, which sometimes could be a little bit tricky. But for us, I think that we were like some kind of good alignment from the beginning. So for us, it was like an interesting collaboration. So we think that this is the key point, right? To find entities that has alignment with the different interests of the consortium. So
thank you. Do we have perhaps another question from the audience, or everything is clear? Oh, great, we have a question. Floor is yours.
Yes, thank you. Thank you for the presentation. I have a question regarding the development of the integrated care model. Have you already some ideas or the basis, which will be the components of this model, if any, or is expected to be developed already still? Thank you.
Okay, thank you again. So we are now at the moment that we have finalized this healthcare analysis, and we are building our integrated care model. As we have 3 clinical sites which are different and their healthcare systems are different, we are planning. We have like 2 different options of this integrated care model to be sure that we are fitting the different healthcare systems that we have, right? We consider that to develop a real integrated care system, we need to develop a platform that includes the different stakeholders and the different healthcare professionals, nurses, clinicians, and allow communication between them. But we are also trying to analyze how to involve patients also in our platform, because we think that communications with patients are also highly relevant in an integrated care model. And as I was saying, we also try to include those different approaches, right? Because on the very beginning, we were really focused on the treatment, on the dressings that we were selecting, but at this is integrated care model, we consider that it's important to take into account other things like the nutrition, like the physical activity, recommendation on that direction, also the hygiene recommendations to the patients on their home. So we are now finalizing that definition, and we are trying to include all these points.
Great. Thank you for the question. And I think now we can move to our first and least but not last presentation from Professor Vitti Tran from the Université Paris-Cité in France and project coordinator of Digital Cactus. So I'll leave you the clicker and the floor is yours. Thank you.
Thank you, Annalisa, and thank you all for being here this morning to listen to us. I am Vitti Tran, I'm a professor of epidemiology at Université Paris-Cité in France, and I will be talking to you about our Cactus project. So, about 40% of adults have one chronic condition, and half of them have multiple chronic conditions. And our care model for chronic conditions is failing. 90% of the USA's 4.5 trillion in annual healthcare expenditures are for people with chronic conditions, and it is not different in Europe. And experts have predicted that no society will be able to sustain this kind of investment for chronic conditions in the next 20 years. Please note that this reference was 8 years ago. For patients, it is not better. Our care model was built in the 19th century for acute conditions, and it is based on short and ill-timed consultations with your doctors. In the end, when you go to the doctor, you spend half a day to go there to get transportation, park, wait a lot of time in the waiting room to see him 15 minutes. And with that, you live 5,000 waiting hours every year caring for your conditions at home, because a lot of tasks of care have been moved from the care structures to patients' homes. For example, if you were a patient with type 2 diabetes, you should spend approximately 143 minutes daily in recommended self-care. So I don't know if you have 2 hours per day to do that, but this creates a huge burden for patients. And this is even worse where patients have multiple chronic conditions, because our care is uncoordinated and fragmented. And this creates high burden of care. And a few years ago, we estimated that approximately 40% of patients would say they would be unable to continue to the same investment of energy, time, and money in healthcare lifelong. So we really need to rethink our care model for patients with chronic conditions. And of course, advances in technology may lead us to believe that we have a solution. And as you would have said before, maybe remote monitoring tools allowing either the passive monitoring of patients' physiological or behavioral data with wearable devices, or the active monitoring of symptoms, for example, through online questionnaires on patients' own smartphones, can help, with the help of algorithms that will allow the real-time analysis of the data. And these tools will probably be embedded in larger ecosystems, for example, as Sheila has said, with active communication tools between patients and clinicians, and online services with online refill systems. So all of this is extremely promising, but it poses us some questions. First, which tools should we use for which patients? We cannot imagine each patient, and we said half of them are multimorbid, with one wearable and one app for each of their diseases. And plus, their doctors should need to connect to different platforms for each of their patients. So this is not possible. Second, as you said, maybe some patients have literacy problems and they do not want to use some tools, while other patients might want to use some tools. So who should use which tools? And second question, how can we effectively blend these tools in the current healthcare practices? It's good to have tools, but our current practices do not use these tools. So how can we make the good implementation of these tools? So patients are ready for that. And I think yesterday Anka asked the question, what is a healthcare for the future for patients with chronic conditions? Again, a few years ago, we surveyed a representative sample of French patients, and we asked them, during COVID, you could experience innovations in your care. You could experience online refills. You could use remote monitoring tools. What would you like to take from this experience in your care for your chronic conditions? And 30 patients with chronic conditions said they would imagine replacing 50% of their consultations by teleconsultations. So, of course, not all of their consultations, but maybe not the first time you meet a doctor or when you have worrying symptoms, but maybe when you need to discuss new exams you have just made or during refills. Maybe this could be teleconsultations. More than 50% of patients with chronic conditions can imagine their treatment adaptations being driven by continuous remote monitoring. So again, how can we do these things? And this brings us to our project. Our project is much more simple than the other ones here. It's just to provide and to develop a tool to help healthcare systems at hospital, regional, or national system to prioritize the digital solutions that should be implemented in the life of patients. So what would be our tool? It would be a patient-reported tool where they would retrace their care journey, for example, all interactions they have with the care system and all tasks they do at home. And when we have retraced that, we identify with patients the pain points where there were unnecessary tasks, redundancy, unmet expectations, failures in care. And when we identify these pain points, we ask ourselves whether digital solutions, if we had implemented them, could have solved these failures in care. When we have this incredible tool, that does not exist for the moment, then we will implement it in registries and cohorts in our partner countries, and we expect to have about 15,000 patients in European countries answering the tool and allowing us to have a comparison between countries, between care systems, between contexts, between conditions. So why does our project contribute to the transformation of care systems? Because current development of digital medicine is completely anarchic. We have hundreds of solutions developed disease by disease, and the implementation is dictated by appetence of physicians and managers rather than the needs of patients. That's why we need this tool. We need robust indicators to assess where there are needs, and so that decision makers can prioritize the right solutions. Second, we know that digital medicine could be an effective solution to some of our problems in terms of access of care, etc. But we must not forget about its potential harms, in particular in the patient-clinician relationships. So we also want to know how does the use of digital medicine affects and transforms the clinician-patient relationship, and how should these tools be implemented to respect the humanistic values of care? Maybe at some point there will be too much digital medicine. We need to strike the right balance. The idea is not to be fully digital nor fully traditional. So a real blended care. How does our project take into consideration the ecosystem? Well, it's difficult because to make the right tool, we need to involve all stakeholders to understand their needs, to have the right indicator for them. So decision makers at policy level, but also hospital managers, clinicians, and patients. And we want to involve all of them to be sure that the tool will answer their expectations. And we will do that with a multidisciplinary team. Yet we need to be humble. Yesterday, Dimitra showed us some slides about the complexity of the healthcare system, and I had a quote from Jeffrey Braithwaite in the BMJ that healthcare is like the most complex system in the world. It is most complex than banking, education, and manufacturing, and no other industry sector has the equivalent range and breadth in funding models, moving parts, complicated clients or patients with diverse needs, so many options and interventions for one needs. So we will try to take into consideration the ecosystem, but we are not completely sure we can do it, but we will try. How do we plan to communicate the scientific evidence generated by our project? Well, of course, we will have scientific publications and we'll have our tool, but there is no need in having a tool if nobody uses it. So what we want is to co-create the tool with end users and to go beyond the tool, make tutorials, help people use the tool and interpret the results so that it can really fit their needs. And that's how we plan to communicate the scientific evidence. Our consortium is 5 countries from France with us at Université Paris-Cité, and SCESI, which is a deep tech company in France specialized in the collection of patient-reported outcomes, the University of Glasgow, the University of North Norway, North Estonian Medical Center, and Leiden University. And to conclude, you need to be cactus to think about that. Thank you.
Thank you very much, Professor. Very great presentation, and very interesting. I don't know if we still have some time because we start a bit late. So yes, we have questions. I saw a hand from the back.
Yes, thank you for your enthusiastic presentation of your project. I just have one question. I was asking myself, how will this be complementary to the whole development of the digital twin?
For me, the digital twin is completely different. Here we want a tool for real patients, asking them where they have problems in their care, to identify where the problems are and to bring solutions. For me, virtual twins and identical twins are more when you have a system and you want to create a replica of the system to test, for example, interventions. So I am not completely sure. I think it's completely, for me, different fields. But this is my take on virtual twins, and that's how we do it in our lab.
Thank you for the question. Yes, please.
Thanks for your very interesting presentation. So the figures you presented at the beginning were very interesting. They are, as you said, quite old. So I don't know if they have evolved, if we have any information regarding the perception of its problems right now. Anyway, I think it's still the same. And my question was, as you explained, I think there is no question about patients taking time to report their problem and to estimate whether they can be treated by remotely or not. But I think, what do you think about the caretakers? About this is more or less self-assessment, what you say. So, and we know that we have a problem with maybe confidence from the caretaker to self-assessment from the patient. How would you address that? Is that clear for you, my question? Yeah.
To answer the first part of the question, the situation has not evolved. And for example, digital medicine is a striking example that we are making the same mistakes as before. So we performed a recent research, unpublished yet, where we took a virtual patient with 5 chronic conditions, and we assessed how many digital tools and digital health technologies this patient could benefit from. And we found that this patient could benefit from 140 different FDA-approved devices and apps recommended by international organizations like ORCHA. And if we were only to focus on the functions that clinicians would think that the most important, this same patient would still have to have like between 15 and 20 different digital health technology tools. So for the moment, we are still as fragmented as before. Regarding your second question, when we are talking about the problems in the care system, we must not forget that the end users of the systems are patients. And if patients do report problems, then we need to account them seriously. So I think we should be very trustful about what they say when they say there are problems. But we should also think that there are two different problems. There are the problems of patients and how we could transform the care so that it is more smooth and does better fit the lives of patients, but also how could we transform the care so that it does not become a horrible mess also for clinicians. For example, with digital technologies, we still cannot imagine a physician needing to connect to 10 different platforms for each of his patients, and 20 different platforms include for when we account for his different patients, etc., etc. So about the subjectivity of this, I think it is completely assumed, because the only way to know if something doesn't work is to ask the person if it does work or not. So we should be very truthful about patients' words.
Yes, of course.
Can I add on? Yeah, we should, but we know that it's not the case actually. So if you're so a physician that is in charge of a patient says, okay, this patient estimates that this can be dealt with remotely. Yeah, I think from what I know, but I'm not a specialist, but from what I know is it's not always the case, and the physician would say no. I mean, this guy, he thinks that it can be done remotely, but I don't want that. I want him to come to the hospital and consult.
I better understand your question. I think it's like transforming the health and care system. Like it's a long road to change the mind, to change medical education, to also change how things are funded. For example, in France, you can have reimbursement when you have a physical consultation or a video consultation, but you do not have reimbursement if you have asynchronous message exchanges with your clinicians. But these things, such as these messages, could save time for both patients and physicians. And if they are correctly reimbursed, maybe we could change the mind of people. So it's like just what we are doing is like one small stone to a huge building, but we need to start somewhere.
Nice. Thank you for the questions. I think, okay, just the last one, please.
And thank you. And actually, I don't have a question. I'm just reflecting a bit, thinking aloud after these 4 very good presentations. Thank you for everyone. I think these all were very good projects, and having run clinical trials myself, I found all of them very, very interesting and good projects. Actually, they were so good that many of them could have been funded from quite a number of funding sources. And especially when talking about the three first projects, so they were relying on technologies transforming micro-level processes of specific clinical disorders. Whereas the fourth one was going a bit higher up and going to more generic transformation potential, which gives, I think, us some food for thought in THCS on what kind of transformative projects in the coming calls could and should be funded. So really, without being at all critical towards the three first ones, I think the fourth one gives us food for thought for next funding rounds. Thank you for all of you.
Thank you very much for this comment. Actually, it's something that we also had in mind when we saw first the presentation. So thank you for pointing out this point. So I think now, before concluding the session, just a few more minutes of your attention. First of all, I would like as well to thank all the project coordinators for their time and of the presentation of today. I think it was very also good engaging discussions, and as THCS I can say we are also looking for the results, the upcoming results in the coming months. To conclude the session, also the THCS coordinating team had prepared actually a second video to present and celebrate the launch that we mentioned, the launch of our third joint call, which was launched a few days ago. So we had the coordinating team had prepared a short video to showcase it. And also I would like to thank all of you to being here with us for this first session of today, the audience online as well. And I think if you have further questions, we can all take them after during the coffee break or at lunch. Thank you very much.
THCS, Transforming Health and Care Systems, is a European partnership established under Horizon Europe and co-funded by the European Commission. The partnership focuses on developing coordinated, harmonized solutions involving EU member states, associated countries, research and innovation funders, and other public authorities. Under this umbrella, THCS launches on November 26, 2024, its third joint transnational call for proposals, better care closer to home, enhancing primary and community care. The goal of the call is to support research and innovation projects that strengthen primary and community health systems through ecosystem-based approaches, equipping policymakers with tools for effective sector transitions. Proposals are expected to address one of two subtopics. Subtopic 1 funds projects focused on transforming health and care systems to prioritize seamless, community-centered care over institutionalized treatment, emphasizing organizational innovations like integrated care models and multidisciplinary teams, as well as operational improvements through efficient tools and digital solutions. Subtopic 2 projects should offer transferable insights with multidisciplinary transnational perspectives and engage stakeholders to support transformative actions like policy development, strategic planning, and change management across European health systems. Expected outcomes and impacts. Projects funded under this call aim to develop innovative, patient-centered care solutions that are practical, scalable, and transferable, with concrete plans for long-term adoption by relevant stakeholders within the health and care system. Projects in Subtopic 1, strengthening the primary and community health and care system, aim to create innovative solutions ready for direct implementation in primary and community care. Proposals in subtopic 2, systemic approaches to modernizing the primary and community care sector, should focus on generating knowledge to enhance seamless care pathways and support evidence-based policy, strategic planning, and health system management. Applicants must belong to one of the following categories: academia, clinical public health sector, private companies of all sizes, and other operational stakeholders. The minimum project duration is 12 months, and projects must be designed to be achievable during a maximum funding period of 36 months. Eligible costs and funding rules and provisions may vary according to the respective funding organization's regulations. Project partners must refer and adhere to their own regional or national regulations and scientific remits. Excellence, impact, quality and efficiency of implementation are the criteria of evaluation of the proposals. Submission procedure. A two-step submission and evaluation procedure has been established for joint applications. Pre-proposals must be submitted by the project coordinator to the JCS via the electronic submission system no later than January 30, 2025. Further information on electronic submission of pre- and full proposals is available on the THCS website and in the guidelines for applicants. THCS. Each of us can make a difference. Together, we make change.